The first of only several disorders that we'll discuss in this chapter is just one eating disorder, specifically referred to as pica. The other eating disorders, which we see more commonly in adolescents, will be discussed fully in psychiatry. Pica is specifically defined as repeated or chronic ingestion of non-nutritive substances, the most common of which are paint, dirt, and even sometimes ice. While this is perfectly normal for children in terms of hand-oral behavior, putting things in their mouth in the first 2 years, after the second year of life, if this doesn't stop, we need to evaluate this fully. The most common predisposing factors are mental retardation or low intelligence and lack of parental nurturing. And it is more common with autism and low socioeconomic status. The major medical issues to be concerned about with respect to this are lead poisoning, iron deficiency, and parasitic infections. Vignette. A 7-year-old boy has problems with bedwetting. The mother says that during the day he has no problems, but is usually wet 6 out of 7 mornings. He does not report dysuria or frequency and has not had increased thirst. The mother also says that he is a deep sleeper. Enuresis is defined as a child continuing to wet himself past the developmental age when continence should have occurred. That is, a mental age of usually 5 years of age. It is a symptom with many possible causes, and it is common in school-age children, with boys more commonly affected overall than girls. Enuresis is classified as primary when the child has never been consistently dry, or secondary when the child was toilet trained and usually has 6 months of consecutive dryness and then has begun wetting again. This is more likely to have psychological causes, that is, in most, or less commonly, organic causes. Again, nocturnal enuresis is bedwetting at night and during naps. It is more common than diurnal enuresis and certainly more common than both diurnal and nocturnal combined. In this situation, most cases are genetic. There's a family history, and the underlying cause is primarily decreased arousal with maturational bladder delay so that during sleep urine is released. In the secondary form of nocturnal enuresis, this one in particular may be related to psychological stressors or recent environmental changes, and it's necessary in the history to ask questions related to these possibilities. Diurnal enuresis is more common in girls and is rare after the age of 9 years. The most common cause is simply waiting too long to void. The secondary form of this needs to be evaluated, and here we have the most common pathological reasons why a child may have secondary diurnal enuresis: urinary tract infections, chemical urethritis, constipation, diabetes, and rarely stress incontinence. The combination of nocturnal and diurnal enuresis is much less common, and in this particular case, the child is more likely to have a urinary tract anatomical anomaly. We only consider at first possibly doing a screening urinalysis and culture and sensitivity. And if these are negative, then finding other positive findings without any history or physical examination suggesting that there might be a specific diagnosis is highly unlikely. Secondary enuresis, on the other hand, particularly with any severe dysfunction, with a previous urinary tract infection, or coupled with encopresis, deserves a further workup. And it is standard of care under these circumstances then to perform a urinary ultrasound, voiding cystourethrogram, and lower spine plane x-rays. If these are negative, no further evaluation needs to be performed. If they're positive, a further urological examination and possibly neurological evaluation needs to be performed. The overall management for enuresis most importantly involves support and education with appropriate behavioral management using positive reinforcement, never any negative reinforcement. For nocturnal enuresis, the best therapy is conditioning with the use of alarm, of which many are available. If that is unsuccessful, pharmacotherapy may be started. The first drug that is typically used is imipramine, which lightens sleep enough that the child can typically detect a distended bladder. Depending on the success of imipramine, DDAVP may next be used, which decreases urine volume. Unfortunately, it has a number of side effects with it and is symptomatic and not curative. Any constipation that is present, of course, must be treated, and no dietary changes in the absence of any obvious food allergies should be made. For diurnal enuresis, treat the constipation first, and then diurnal enuresis seems to be most amenable to bladder stretching exercises with timed voiding every 90 to 120 minutes. Encopresis is defined as the passage of feces into an inappropriate place after the age of 4 years. Less than 4 years of age, boys and girls are equally affected by this, whereas afterwards it is much more common in boys. As in enuresis, encopresis is defined in terms of primary versus secondary. With primary enuresis, this occurs from infancy onward, and in secondary it occurs after toilet train has already been achieved. We can also divide this further in terms of being retentive versus non-retentive. Retentive encopresis occurs with constipation, where we have hard stool with overflow and incontinence. This, in fact, are most of the cases. Non-retentive occurs without constipation. The major associated causes are urinary tract infection, a number of organic causes such as Hirschsprung disease, spinal dysraphism, chronic diarrhea, certain drugs, and certain endocrine problems, and then a myriad of behavioral, environmental, and psychosocial problems, particularly with primary encopresis in males, who typically have global developmental delays. With secondary encopresis in all children, there's also a higher amount of psychosocial problems and conduct disorders. The first part of the evaluation after the history and physical is to assess fecal retention. Finding impacted stool on rectal exam is sufficient. However, without that finding, a plain X-ray is needed. Then the constipation needs to be managed chronically. The first most important thing is to clear any fecal impaction. Have the patient use the toilet on a regular basis after every meal. Teach the parents principles of positive reinforcement, once again, with no punishment involved. They need to learn the principles of ongoing behavioral management. From a dietary standpoint, the patient should be put on a high-fiber diet with increased fluids. And in the cases where psychosocial disturbances are felt to be operative, then a mental health evaluation with possible therapy may be needed. The parasomnias are episodic nocturnal behaviors which involve cognitive disorientation and autonomic and skeletal muscle disturbances. They are typically common in young children who have relative immature central nervous systems, much more common in children than in adults, and generally abates with age. The third of the most common parasomnias in children are nightmares. This occurs in the last third of the night during REM sleep, because REM sleep in young children is more common in the last third of the night. And nightmares involve mild to high agitation and autonomic arousal with little motor behavior. There's a low arousal threshold. Child is awake and agitated after the event, and if prolonged, there may be daytime sleepiness with vivid recall. It's very common with no family history, and the treatment is basically the same as the other two parasomnias. The management is primarily parental education and reassurance, and making sure to avoid any exacerbating factors. That is, there should be good sleep hygiene principles. Safety precautions around the house need to be instituted because of possible displacement from the bed. Rarely does the child require any other form of therapy unless it becomes frequent and persistent, in which case the child should be evaluated for anxiety disorder and possible child abuse.